Hello, everyone. We are now going to go over the peripheral blood flow cytometry from a 67-year-old woman with leukocytosis and numerous circulating blasts. Let's start with CD45 versus site scatter. So as you see here, the lymphocytes have the bright CD45 expression with low site scatter. Very few monocytes are seen, which have higher site scatter than the lymphocytes and have similar CD45 bright expression. And in the granulocytes gate, we have 25% of cells which have very high site scatter due to their granularity in the cytoplasm. And these have dimmer CD45 than lymphocytes and monocytes. We have a big chunk of cells, 45% of all cells analyzed in the blast gate. And this blast gate is indicated by a dim CD45 expression and low site scatter. Now let's follow through the blasts, which are painted red in the subsequent plots, and see what they express. In the CD34 versus CD33 plot, we see that these blasts express CD34 and maybe a very dim partial CD33 expression. There is a partial CD117 expression. 117 is a myeloid marker. CD34 and HLA-DR shows the blasts are partially positive for HLA-DR. And they are negative for CD15. They are positive for CD38. And then in the next tube, we see that these blasts express a partial CD13. So far they are positive for the myeloid markers CD117, CD13, and partial CD33. All markers are pretty partial. And when we go to the monocytic markers, they're negative for CD11B, they're negative for CD14, they're negative for CD64. So they do not express any of the monocytic markers. The blasts are homogeneously positive for CD56, which is an aberrant marker. And they express a partial CD71. CD71 is commonly associated with erythroid lineage, but it's not very specific for erythroid lineage blasts. It can be expressed by myeloblasts or lymphoblasts. However, erythroblasts express a very bright CD71, which is not seen here. Now, when we come to the T cell tubes, we see something interesting here. There is a small population of blasts that express CD2, and then these are pretty distinct from rest of our blast population, which expresses CD34 and are negative for CD2. These blasts are all negative for CD4. And again, in CD4 versus CD2, we see a small population that is positive for CD2. And surface CD3 is uniformly negative on all the blasts. And again, in the CD7 versus CD34 plot, we see a small population that is positive for CD7, and they also have partial CD34, just like the other blasts. And in a 7 versus 2 plot, we have that distinct population that is positive for 2 and 7. So it looks like there are two populations of blasts here. One that is that had the phenotype of partial CD117, 13, and 33 expression, and there is a smaller population, which may be like, if we put together, it would be like around like 10% of the blasts that would express 2 and 7. But it is important to remember right now that this could be contamination from some other nearby cells, especially NK cells can express CD2 and 7, and they can express 16 and 56. So it's not, at this point, we cannot say if these are really a separate population of blasts or not. We have to follow through to see what they express. Similarly, NK cells can be negative for CD3 and CD5 also. So just with CD2 and CD7, we cannot determine if these are blasts. We have to keep this in mind and follow through. And all the blasts are negative for CD8, and they're negative for the B cell markers 19, 10, and CD20. This mild spray of cells, that doesn't look real, but anyways, they don't express CD19, so we don't have to worry about them. Now coming to the cytoplasmic tube, here we see that the blasts, which are in the royal blue color, accounting for 42%, these do not express the B cell markers 19 or 22. And again, we see the large percentage of the blasts express CD34. There is a smaller subset that does not express. However, we see that there is a small subset that express cytoplasmic TDT. We can see that here too in the 22 versus TDT plot. Our blasts are negative for MPO. And then again, we see there's the partial CD117 expression in the blast in these two plots and also in these plots, but these are negative for MPO. And CD9 is negative. Then when we go to the cytoplasmic T cell tubes, we see that the blasts are painted in the green here, fluorescent green, but it also includes some cells painted in red. So if we see here, majority of the blasts, like we saw in the previous tubes, are CD34 positive, and there is a small subset that is cytoplasmic CD3 positive, which expresses a partial CD34. These are 1A negative, CD1A negative. They express a partial CD5. And here in the cytoplasmic CD3 and TDT tube, we see a distinct population here. That is almost 6% of all the cells, or if we include both the cytoplasmic CD3 positive and the TDT negative cells, it would be like around 11% of the cells. These express cytoplasmic CD3 and TDT, which means these are immature T cells. And with the previous plots, we also saw this distinct population, which again expressed 2 and 7 and did not express 4, 8, or surface CD3. So this is consistent with a separate population of immature T cells and a larger chunk of the CD34 positive blasts that expressed myeloid markers are seen here. So we have two different blast population here, which is suggestive that this is a mixed phenotype acute leukemia T-myeloid subtype. Now, one question that you might have is sometimes T lymphoblasts can express myeloid markers, especially the early T precursors, as you see in ETP-ALL, where they will express myeloid markers like CD117 or 13 or 33. Why is this not that? But here, you see two distinct populations, that one expresses only the T cell markers and the other expresses the myeloid markers. But in ETP-ALL, it will be the same population of blasts that expresses both the T cell markers and the myeloid markers. So that helps differentiate. And sometimes MPAL, or the mixed phenotype acute leukemia with T-myeloid type, the same population of blasts can express both the T cell markers and the myeloid markers. But in that case, you would always need MPO positivity, because MPO is considered the specific marker for a myeloid lineage. So if MPO is positive and it expresses T cell markers in the same population of blasts, you can go ahead and call it as T-myeloid leukemia. But here, because it is two different subsets, one distinctly expressing just the myeloid markers and the other expressing only the T cell markers, we don't need the MPO positivity, and we can call it MPAL even without that. So yes, when we report, we can call this mixed phenotype acute leukemia T-myeloid type. And this case has easily 45% blasts. So for MPAL, the criteria is that you need 20% blasts, but each lineage need not be 20%. You need 20% together, all the blasts put together. So we satisfy that criteria. And as always, we have to give a detailed phenotype of these blasts in the initial stages. One important reason why we need to give these complete phenotype is because when these cases relapse or during the course of treatment, they can have a lineage switch and manifest just as relapsing or recurrent or persistent T-ALL alone, or just myeloid leukemia. So and therapy can sometimes be effective on just one of the lineages, and the other lineage can still remain. So it is very important to document the percentage of each of these lineage blasts in your report, along with the detailed phenotype of each of these lineage blasts. Thank you.